Hi to everyone that's trickling in. We're just giving a few moments to allow more participants as well. All right, so let's get started. So hi everyone, my name is Alice Alon. I wanted to thank you all for joining today's member webinar that's titled Psychiatric Genetic Counseling, Emerging Access Points Through Holistic Primary Care and Precision Medicine Integration. So just some housekeeping as we start. So we do encourage questions to be asked throughout the presentation. As a courtesy to our presenters, all attendees have been muted. Please utilize the Zoom Q&A box for questions you may have throughout the presentation. The chat function is also available for discussion throughout the talk. And questions will be read aloud during the last 10 minutes of the webinar. So for today, we have 4 different learning objectives. The first is to consider new and emerging access points to psychiatric genetic counseling through primary care. The second is to compare and consider the different models of service delivery and psychiatric genetic counseling considerations for pre-test counseling and pharmacogenetic results disclosure. The third is to examine the experience, including benefits and challenges, of implementing psychopharmacogenetic service delivery through multidisciplinary team-based primary care. And the fourth is to describe the unique genetic counselor and pharmacist partnership in the pharmacogenetic guided psychiatric medication journey for patients/clients. So today we're joined by our 3 speakers. So our first speaker is Natasha Berman, and Natasha Berman is a primary care clinical genetic counselor in the UPMC Family Medicine Department in the UPMC Primary Care Precision Medicine Clinic. She is a co-author of Genetics for Family Physicians in Current Diagnosis and Treatment in Family Medicine in the 5th edition. She has lectured and published on the topic of primary care genetics. Natasha is also a genetic counseling student supervisor and adjunct faculty at the University of Pittsburgh. She has specific research focus on access issues and disparities in genetic services and firmly believes that primary care is the future of genetic counseling. Our second speaker is Christine Monroe, and she is the Director of Recruitment and Admissions for the University of Pittsburgh Genetic Counseling Program, holding an adjunct faculty position since 2017. Christine also works as a genetic counselor for the UPMC Primary Care Precision Medicine Clinic. She is a graduate of the University of Pittsburgh Genetic Counseling Program and Public Health Genetics Program. Christine is working in several specialty areas relevant to today's talk, including primary care and pharmacogenomics expertise. Christine's research and clinical interests center around innovative ways to scale genetic service delivery with the goal of increasing equitable access to care. And our third speaker is Priscilla Carrion, and Priscilla Carrion is a genetic counselor and clinical associate professor at the University of British Columbia, Canada. Her clinical research expertise includes exploring the value of embedding genetic counselors in novel and emerging areas to increase access, promote empowerment, and facilitate evidence-based proactive health strategies. She will be speaking today about her experience within an innovative role as a genetic counselor integrated in a multidisciplinary primary care family practice team that primarily provides care for marginalized patient populations. She also provides forward-thinking, proactive genetic counseling services through integrated primary care with MedCan in Toronto, Ontario, Canada. So with that, I will pass it over to Natasha.
Thank you, Alice. I'm Natasha I use she, her pronouns, and both myself and Christine are based in Pittsburgh, and we would like to respectfully acknowledge the Seneca Nation, Haudenosaunee Confederacy, Shawnee, and Lenape people on whose traditional unceded territories we live and work. We recognize that the Indigenous individuals and communities who live here now and those who were forcibly removed from their homelands. In offering this land acknowledgement, we affirm Indigenous sovereignty, its history, and experiences. Next slide.
And my name is Priscilla Carrion. I use she, her pronouns. I work, live, and play on the waters and lands now known as Victoria, British Columbia, Canada. I would like to respectfully acknowledge the Lekwungen and Wasanich peoples of the Songhees and Esquimalt nations on whose traditional unceded territories I live and work. These nations have agency over these waters and lands. And with respect to my positionality as well, my parents immigrated from the Philippines to Vancouver, and I'm also affiliated with the UC Vancouver campus located on the traditional unceded territory of the Musqueam people.
Neither myself nor Christine have any disclosures.
And I have no financial conflicts of interest to disclose. And as my colleagues already mentioned, I am employed as a genetic counselor for a privately held health and wellness company in Toronto, Ontario.
Our agenda today includes a discussion of psychiatric genetic counseling delivery through multidisciplinary team-based primary care models, reviewing the Pittsburgh model in action, and providing primary care genetics as an access point for psychiatric genetic counseling, as well as review of the use of trauma-informed approach in providing a holistic patient care. Next slide. I will specifically be speaking about the experience of leveraging primary care as a space to improve access to genetic services and work as part of a multidisciplinary team to provide holistic patient care. We hope this will act as a good foundation for learning about the different clinical experiences. Next slide. So the first question is, what is primary care? Primary care is defined by the committee. The future of primary care is the provision of integrated, accessible healthcare services by clinicians who are accountable for addressing the large majority of personal healthcare needs, developing a sustained partnership with patients, and practicing in the context of family and community. The actual definition of primary care has really grown and developed over time. But when we think of primary care, we think of the word prime, right? First contact for patients and families. Primary care can include care across the lifespan and multiple generations. Realistically, this often includes multiple different types of clinicians, such as family medicine, internal medicine, and even OB-GYN. In practice, we consider those clinicians who provide care across the lifespan and act as a regular touch base for patients to be involved in primary care. Much of our discussion will be based around the idea of family medicine as a primary example of primary care. Next slide. Primary care clinicians are frontline for care and will be the frontline for genetics care, even if they're not necessarily feeling ready for that. Primary care or PCPs are often considered gatekeepers for other types of care, even genetics, and oftentimes act as the first stop for patients who might have questions about their health, family history, or even their genetics. Primary care is the first medical contact for most patients. They oftentimes are the ones who are updating and reviewing family history, identifying changes in personal circumstances, new diagnoses, and things like that. And they are oftentimes the one who are managing complex medical needs and even like psychiatric and pharmaceutical needs. Multiple studies indicate that patients will come first to their primary care clinician. This could be concerns related to family history, their own health, or even direct-to-consumer genetic testing results. This really highlights that element of trust that many patients have in their primary care providers. And that primary care space is actually a really good starting point because most primary care providers have the additional power of triage and research. There's a saying in family medicine that they know about 70% of everything, but they know when to triage back to specialists. And that's an important thing to keep in mind while we talk about that primary care space. Next slide. There's lots of overlap between primary care types of care as well as genetics. And so I'm really going to try to capitalize and highlight in today's conversation those related to mental health management, prescription management, and chronic disease management. We do know that family medicine is already oftentimes a multidisciplinary team. So oftentimes finding physician, nurse practitioners, PAs, dietitians, social workers, and pharmacists, and that it may be helpful to start including genetic counselors as part of that team, considering the large amount of overlap where primary care can also be involved in genetics care. Next slide. So many patients, our clinic specifically in Pittsburgh sees patients who have concerns for multifactorial conditions, but many genetic counselors will hear that phrase, well, this runs in my family, when the patient isn't necessarily talking about something strictly monogenetic. This can be something as straightforward as sort of a more familial cancer rather than a hereditary monogenic cause. It could be diabetes or a variety of other conditions that we know have a genetic influence but are not related to one single gene. Specifically, we think about psychiatric concerns falling into this bucket, where we know there can be a variety of genetic and environmental components. There's also lots of evidence that indicates, specifically within the psychiatric realm, that patients really benefit from these discussions with genetic counselors. And in our own practice, there's anecdotal evidence that there is benefit from having these discussions and really allowing the patient to feel heard. Next slide. So primary care genetics is actually the ideal landing space for genetics and specifically psychiatric genetic care. Psychiatric genetic counseling, it's easy to imagine how we might integrate a genetic counselor into that already existing team of maybe a pharmacist and an MD, especially when it's not uncommon to have things like social workers. And so you can think about how this team as a whole may actually be able to really enhance the care provision that we do for patients. More often than not, your GP will be the one who manages psychiatric care, sometimes with the help of a psychiatrist, and embedding a GC in that primary care space can allow us to provide more holistic care for patients, especially given the knowledge that there is a benefit to having a space for patients to talk through this type of genetic concern. Next slide. We know that primary care, just like genetics care, is oftentimes trained to take care of patients through that lifespan and being able to address patient concerns as they get to different points or as new information is added to them or new diagnoses. This also means that in families where there are histories of psychiatric concerns, we can allow larger conversations that can benefit a patient, especially as they grow and might need more support related to their mental health concerns. Next slide. One of our primary goals was to address access points in terms of pathways to genetics. And so this slide actually identifies many of the different generalized barriers to accessing genetics. I really want to focus more specifically on pharmacogenomics and psychiatric concerns. And so there is that perception of unfavorable cost effectiveness, insufficient understanding of the potential benefits and even concerns related to genetic counseling and pharmacogenomics that can act as a barrier. Clinicians may also feel that there are ethical concerns, such as the potential for increased stigma or discrimination based on that historical division of health insurance and mental health. There are also potentially limitations more specific to pharmacogenomics in terms of limitations related to results, perceptions of reliability, and issues of cost related to testing with or without insurance. And even implementation of pharmacogenomics can be difficult. We think about integrating into the electronic medical record, and that can be very tricky and costly for healthcare systems. And there's not a widespread way of doing this, which results in inconsistencies in terms of the results, the information provided for patients, cost, insurance coverage. And then there's lack of standardization of this type of testing. So not all genes are on all panels. Drug team pairs may not be represented on specific panels, and there's specific limited utility in psychiatric genetic counseling at this time. There's also a lack of generalizability, especially due to that historic data primarily being based in the white European population. And finally, we run into issues about how to follow up with patients. how often and who needs to be doing that. This is particularly problematic for pharmacogenomics because this is truly a living result. CPIC guidelines and information is ever changing and can require regular reinterpretation as we learn about more information. And so we think that a lot of these issues actually can be addressed through the integration of a genetic counselor into the primary care space. I think Chris is going to walk us through a little bit about how that might look.
Perfect, thank you. So next we'll take a look at the Pittsburgh solution. Next slide. So we are excited to share a little bit about our experience in Pittsburgh as a model that incorporates psychiatric genetic counseling through pharmacogenomic referrals in a primary care clinic. I'll say that the ability to provide psychiatric genetic counseling through these PGX referrals was a little bit of a happy accident, but one that's created an important access point for patients. So this here is our team. We have Dr. Mazert, our physician lead and director of the program. We then have our newest addition, our nurse practitioner, Brianne. We also have 2 PharmDs, Dr. Empey and Dr. Berenbrock, as well as 1.5 FTE genetic counseling effort through Natasha and myself. So the clinic was established in 2019 and has since grown to include a nurse practitioner and extra full-time GC effort. Next slide. So our clinic is embedded in a larger family medicine practice in Pittsburgh. We are currently serving patients through the hub and spoke model. So we are acting as the primary care genomics experts placed to strategically serve multiple primary care physicians and clinics. Next slide. So we have several branches to the clinic. We have our primary care branch where we are determining best practices for integration and advancement of genetics into primary care. We have our precision medicine branch where we are advancing best practices for clinical delivery of precision medicine and also filling a gap for a lack of broader adult genetic services in Pittsburgh. So receiving referrals from other subspecialties. And last, we have our genomics education efforts. Next slide. So the clinic has a multidisciplinary workflow where every patient sees the genetic counselor, the PharmD as needed, and physician or nurse practitioner. I'll share a little bit more later on about the division of responsibilities in relation to the pharmacogenetic referrals and pharmacogenomic testing specifically. Next slide. Through this multidisciplinary clinic model, we are able to provide pre-test counseling and post-test counseling services. We do have a paper published on the clinic if you'd like to read a little bit more about the model. Next slide. So this is a bit of a busy slide, but it shows a breakdown of the test orders through our clinic. This data is a little bit older, so it was pulled in early 2022. I apologize, our database was under a bit of construction as we put together this presentation. In the top right corner, though, you can see the clinic's second largest indication and test order type is pharmacogenomic testing. I can anecdotally share the largest portion of these PGX referrals are psychiatric medication indications. Next slide. So our pharmacogenomic referral sources include local psychiatrists, primary care physicians, other subspecialty clinics, our pediatric genetics clinic, and sometimes a patient is actually referred for something other than PGX. And through a comprehensive personal and family history intake, we learn the patient may benefit from further PGX discussion. We accept all adult patients and may triage to our high-risk cancer clinic or ophthalmology genetics program or cardiogenetics programs if needed. We do accept pediatric patients for pharmacogenomic testing only, since we have a wonderful pediatric genetics program in Pittsburgh. There are no eligibility criteria or indications that we don't see currently. Next slide. So we see patients at various points in their pharmacogenomic journey. Majority of the time we see patients before they've had testing, but we've also had patients who've done direct-to-consumer testing and now have questions. And sometimes we see patients after providers ordered PGX testing and then consults for help around guidelines and interpretation. Next slide. So genetic counselors have complementary skill sets to our pharmacy colleagues. Genetic counselors are well equipped to work alongside them through our ability to provide education, translate literature, assess risk, facilitate decision-making, provide support, and help with lab or test selection. It is outside of our scope, though, to make medication recommendations based on PGX results or assess the value of testing for a patient based on past medication history. So this is where the GC-PharmD partnership can be beneficial to patients. There are many great papers out there that support this collaborative model. Next slide. So here is a breakdown of our clinic's PGX practice model through the division of responsibilities based on expertise and scope of practice. So in a pre-test session, the genetic counselor does a family history risk assessment, provides a genetics overview, and highlights the difference between a pharmacogenomic test and a diagnostic test, or lack thereof in the world of psychiatric genetics. We're able to discuss limitations and manage expectations and facilitate informed decision-making. The pharmacist performs a medication review and tailors discussion around benefits and limitations of testing specific to a patient's past medication history and provides recommendations to testing to the MD. The physician reviews all the information, makes interim recommendations, and bills for services. In the post-test session, the genetic counselor reviews the results with the team and is available as needed and may help guide any recommendations for family members. The pharmacist reviews all of the pharmacogenomic guidelines and makes recommendations there. The physician reviews everything and makes sure any necessary alerts are in the chart and bills for those services. Next slide. So we would like to share our anecdotal observations about this unique partnership and service delivery model through the multidisciplinary approach, holistic view of the patient, that one-on-one support from a PharmD, the well-documented benefits of psychiatric genetic counseling, and having something tangibly actionable through a pharmacogenomic test. Patients have shared feeling heard and a sense of support and empowerment. This is definitely something that we'd love to support through more formal research in the future. Next slide. So next, we'd like to share a couple of cases to highlight our case. Next slide. So we had a pediatric patient that was referred by their psychiatrist for consideration of pharmacogenomic testing. The patient had a history of bipolar disorder, ADHD, and learning disability. They had trialed 11 medications that caused side effects or were ineffective. And then there was also a family history of psychiatric disorders, so schizophrenia and bipolar disorder, as well as intellectual disability and learning disabilities. During the appointment, the genetic counseling team was able to offer psychiatric genetic counseling and through a comprehensive family history intake, identify a recommendation for referral to medical genetics, given the family history of intellectual disability and psychiatric disorders. We were able to discuss the important difference of pharmacogenomic testing and any diagnostic testing. And we were able to offer support and really manage expectations, especially since the patient was landing with us after an extensive medication trial history. And we know the limitations around informing psychiatric medication choices through PGX testing. And with that, I will pass it back over to Natasha for the next case.
So our next case is also another pediatric patient we saw in clinic. This patient was referred after they had a history of aggression, ADHD, anxiety, anger outbursts, major depression, and separation anxiety. So all really compounded by a parent's divorce and their inability to see eye to eye in terms of treatment related to this patient. So this patient's mother was actually a nurse and very committed to finding medication to help deal with some of these psychiatric concerns, whereas the father was kind of less sold on that plan and less sold on the idea of psychiatric concerns in general. And this all combined in a way that was particularly difficult because of ongoing conflict surrounding custody of this patient. So because there was a lot of tension in the family, it was really important to work through aligning goals and setting good expectations. One of the primary considerations and reasons for testing was that the father, who was much more conservative about the idea of trialing medication, felt that using pharmacogenomics would allow the whole family to feel really confident and that there would be less guesswork in trialing medications. And so facilitating that pharmacogenomics testing really helped the whole family feel like there was no stone left unturned in trying to assist this child. Next slide. Our final case is a patient that was a new patient for us who was referred from within our own practice. This patient had a history of a recent diagnosis of ADHD and had problems being on and off medication throughout the summer, finding that the side effects were too big and didn't outweigh the benefits. And this was something that had bothered them previously with other types of medication. We actually, during this intake, found that the family history was really quite sparse. And in fact, most of the family history ended up with a caption of limited or no contact. While the patient's parents did have a history of psychiatric illness, there was lots of tension in the family. My patient reported that they did not have contact with her family for the past about 10 years due to needing to create boundaries. So while our session covered a lot of the basics of limitations and potential benefits of testing, we also talked about sort of that inheritance and the JAR model for psychiatric concerns. Ultimately, the patient was able to express that her psychiatric concerns or not being able to find medication was not a failing on her end. But we were also able to reinforce all of the awesome things that she was doing, like establishing good primary care and being a good self-advocate. We also reinforced how important and great it was that she was able to set boundaries with her patients, even though that can be really difficult. And specifically chose this patient story because it highlights some of that trust in terms of holistic care, because this is a patient who was within our family medicine group. I was able to leverage some of that trust she already had with her primary care doctor to open the door to having some of these conversations and allowed for a really productive genetic counseling visit. So with that, I will hand it over to Priscilla.
Thank you, Natasha. So I'll be speaking about my experience as an embedded genetic counselor within the primary care family medicine clinic, and particularly how I aim to take a culturally safe and trauma-informed approach with the goal of providing holistic patient care for a largely marginalized client population. So in the overview of what I'll be talking about today, I'll give you more information about the Gen Council project that I was working with, as well as the clinic setting for the primary care integration, and talk more about the mental health and substance use evidence that I drew upon with respect to applying principles of a culturally safe and trauma-informed approach to care and genetic counseling. And I hope to tie everything together in a case example to give you more of a sense of my experience of providing psychiatric genetic counseling to marginalized and vulnerable patient populations. So the Gen Council project is funded by Genome Canada, and it's focused on investigating the clinical, ethical, and economic methods to ensure equitable access to genetic counseling and testing for all Canadians. So really an innovative research initiative to increase access. And I work closely with Dr. Janine Austin in the practice activity of this research initiative to look at exploring innovative methods for effective genomic counseling, including the evaluation of the primary care integration. So the Kool-Aid Community Health Center is where I was integrated and embedded within a 15-month pilot, and it is located in Victoria, British Columbia. They take a multidisciplinary team-based approach to primary care. So I was embedded within a clinic of primary care physicians, nurse clinicians, practitioners, registered clinical counselors, dietitian, physiotherapist, as well as a pharmacy team. This clinic services over 7,000 clients, including individuals who are underhoused or experiencing homelessness, mental health challenges, infectious disease, and problematic substance use or chronic illness. I wanted to also acknowledge that a significant proportion of Kool-Aid clients, around 20 to 30%, depending on the program, have an Indigenous heritage. And Kool-Aid partners with the Indigenous Victoria Native Friendship Center in providing this primary care to these individuals. To give you context of my experience that I brought into the primary care integration, I had experience working with vulnerable patient populations as being embedded in the BC Psychosis program at UBC Hospital, which is a tertiary specialized program, where I was providing psychiatric genetic counseling through research to patients with treatment-resistant schizophrenia. So to give you an overview of the clients that were referred to me for the primary care integration, these were all internal referrals from my team at Kool-Aid. And the majority of clients I had seen were referred for psychiatric genetic counseling, but it wasn't uncommon that I actually would have kind of a dual referral where I might be asked to see a client to talk about their mental health concerns, as well as any other common complex conditions that they may be personally managing, like diabetes or celiac disease, for example. And initially, I may also receive referrals for people who might be concerned about a hereditary predisposition in their family, like family members impacted by cancer, cardiovascular disease. And often these clients would also be managing mental health concerns. And so I would very much kind of take an approach led by the clients, where if they wanted to discuss all of their concerns within one genetic counseling appointment, I would accommodate that. Some clients preferred to kind of keep that discussion of their concerns about other chronic illness or physical health concerns to one appointment, and have a dedicated appointment to psychiatric genetic counseling. So again, really just meeting clients where they're at in their journey, and accommodating what makes sense for them. Many of the clients that I've acknowledged already that were referred for psychiatric genetic counseling had a significant trauma history. And from my prior experience working with vulnerable patient populations, I was mindful that a significant trauma history can affect the trust, ability of clients to open up and engage and really fully process the information shared in a genetic counseling appointment. And trauma encompasses the experiences that can overwhelm an individual's capacity to cope. And so I've included the visual of the JAR model mental illness that we use in psychiatric genetic counseling, to help highlight, the impact of trauma, represented here by this really large blue triangle in a jar that's taking up more space and contributing to someone's vulnerability or chance to develop a mental illness in their lifetime. I wanted to also acknowledge that the most marginalized members of society are often profoundly affected by trauma, and evidence has shown that among marginalized groups, medical distress is significantly higher in healthcare in general, and in genomic medicine in particular. A trauma-informed approach has been proposed to help mitigate some of these effects of the medical distress. When working with marginalized groups, I think it is important to take into consideration the 6 key principles of a trauma-informed approach to care. Many of these things, as you will kind of notice as I go through the description, are often embodied within psychiatric genetic counseling process, and the origins are from the mental health and substance use service literature. I do feel that they can be applied more broadly across other specialties of genetic counseling in your interactions with vulnerable patients and clients. So the first here is safety. It's important to ensure that both the physical setting is safe and interpersonal interactions promote a sense of safety with your patients and clients. Trustworthiness and transparency. The goal here is to build and maintain trust with clients and family members. Peer support is key for establishing safety and hope, building trust, enhancing collaboration, and utilizing client stories and lived experience to promote recovery and healing. As genetic counselors, we may not have similar lived experiences to our clients, but we can speak to our experience in supporting clients and patients and helping to connect them with peers with lived experience. Collaboration and mutuality. Here, the importance is placed on partnering and leveling the power differences between healthcare provider and clients, demonstrating that healing happens in relationships and in the meaningful sharing of power and decision-making. Empowerment, voice, and choice. This is where clients' and strengths and experiences are recognized and built upon, including resiliency and the ability of individuals and communities to heal and promote recovery from trauma. And lastly, cultural, historical, and gender issues. When reflecting on these, we aim to actively move past cultural stereotypes and biases based on race, age, gender, identity, etc. We want to leverage the healing value of traditional cultural connections and recognize and address any historical traumas. Cultural safety, for those who may not be familiar with this term, refers to what is felt or experienced by a patient when a healthcare provider communicates with the patient in a respectful, inclusive way, empowers the patient in decision-making, and builds a healthcare relationship where the patient and provider work together as a team to ensure maximum effectiveness of care. At the individual level, a genetic counselor can prepare for a trauma-informed approach through engaging in strategies to promote self-awareness and protect against vicarious trauma, which it results from empathic engagement with traumatized clients and their descriptions of their traumatizing experiences, and also being mindful of ways to protect and manage compassion fatigue and burnout. So I've included here an overview of the ABCs of addressing vicarious trauma, as well as outlining some strategies that we can engage in to help protect ourselves from vicarious trauma. I wanted to acknowledge also within this slide that the negative impacts of compassion fatigue and burnout have been studied extensively in genetic counselors, with more recent research actually looking at the value potentially of genetic counselors engaging in things like mindfulness to increase empathy, work engagement, and decrease burnout and compassion fatigue. So in terms of increasing trauma awareness within your own genetic counseling practice, I thought I would share my journey through some of the continuing education opportunities and trainings that I had brought with me into the primary care integration. So two being the Indigenous cultural safety training that I had completed, as well as reviewing the trauma-informed care and practice from the mental health and substance use literature. And so these are trainings and learnings that I was able to experience during my time working with BC Mental Health and Substance Use Services. And when I started the integration, I continued with my education and learnings, and I wanted to share and highlight two of these opportunities that I had engaged in because they are opportunities that were developed specifically for genetic counselors. So the online course provided through the NSGC for implicit biases and practical strategies to address them, as well as the Amplify course on gender affirming care. I think that I've highlighted, just some of the experiences that I've included in my journey, and I've added some additional resources in a resource slide towards the end of our talk. So now I'd like to share how I incorporated a culturally safe and trauma-informed approach within my psychiatric genetic counseling practice during this primary care integration. And I hope to kind of highlight kind of key moments here in the genetic counseling process and how I tried to do that. So within the contracting, to promote safety, I would check in with my clients if they had a private space that they felt comfortable talking to me from when we were engaging in either phone or video appointments. This is something that I had to pivot to during the pandemic, when unfortunately the opportunity for in-person appointments in a safe private space in the clinic wasn't possible. I also would check in with all of my clients if they had a support person that they would like to include in the appointment. And I would spend a bit of time at the beginning of each session to explore self-care and coping strategies, particularly if clients were feeling anxious coming into appointment, or if they were feeling like they were worried that they might start to feel triggered by some of our discussion. To facilitate transparency, I would also acknowledge that only their healthcare providers at Kool-Aid would have access to the chart notes for our discussion. So acknowledging kind of that access from their doctor, nurse, and registered clinical counselor typically. Within a psychiatric genetic counseling appointment, I would highlight that we value bi-directional knowledge sharing and hopefully helping level power the differential with my clients, thinking about supporting those principles of collaboration and mutuality. Always with my clients, I would let them know at the beginning that if they need to take a break at any time to engage in some self-care, to please let me know. But I would remind them that I would do a midpoint check-in to see how they're doing and give them the choice whether they want to continue the discussion or if they would like to consider reconnecting on another day. At the end of the appointment, I would also do a check-in again in terms of how are they feeling. And we would have that discussion for what would be the self-care plan, bringing in some of the strategies for coping and managing that we talked about at the beginning and throughout our genetic counseling appointment. And clients would share with me their plan in terms of things like going for a walk or reading after the appointment, or if they preferred to engage in more culturally meaningful methods like smudging or prayer. And then for the clients that had experienced a significant trauma history, including PTSD, who would benefit from a follow-up call, I would offer, the opportunity for me to call them, 1 or 2 days after our session just to check in. And I found this was especially helpful for the Indigenous clients that I met with after the initial family history appointment, because often it would take some time for them to process kind of the impacts of that discussion. And I received feedback from them that it was appreciated that I checked in to see how they were doing. And what I'd like to do now is end my part of the talk with a case example that I hope kind of ties in how I tried to take a trauma-informed and culturally safe approach within my primary care genetic counseling practice. And so this is a visual of the family tree for my client, an Indigenous man here in his 60s who was referred to me from his nurse practitioner at Kool-Aid to talk about his management of his mental health, including his history of depression, PTSD, and substance use disorder as well. He also shared that he had been managing his physical health conditions, including recently experiencing shingles and pneumonia and managing ongoing chronic respiratory disease. So in the contracting with my client, we started off with some discussion as well regarding how much lived experience of trauma and abuse he would share in terms of his comfort level. I wanted to be sensitive to the potential triggers of trauma and the chance for my client to experience any dissociation given his recent experiences of flashbacks to his childhood, to the time when he was taken away from his family and his culture and experienced abuse in residential school. So again, that was a sensitive discussion around, sharing his story to be heard and feeling connected, but also being mindful of being kind to himself and having a plan in place for exploring kind of self-care if he was noticing some emotions kind of being coming back to the surface. And we also explored his resources and supports. So he shared with me that he had completed trauma-focused counseling in the past with a psychologist, and he was open to the idea of genetic counseling with the goal of engaging in services that could further promote his healing and his ability to manage his mental health. He gave me permission to connect with one of his friends as a support person if there were concerns about him and I was having difficulty checking in or connecting with him after our appointment. With respect to our genetic counseling discussion, we talked about and reviewed his family tree, looking at the multiple generations and family members impacted by substance use and mental health issues, and the connection there with their experience as being residential school survivors, acknowledging, that large triangle in his jar as well as his family members' jar, representing the stressful life experience from that trauma that was taking up space and impacting their mental health as well as their physical health. For those who may not be familiar, intergenerational trauma encompasses how communities and groups as a whole experience trauma and how the effects of trauma are often transmitted from one generation to the next. In our discussion, we went on to explore guilt, the guilt that he shared that he experienced with respect to how his addiction impacted his parenting, and his guilt around his daughter also having issues with alcohol use. We acknowledged, often in a psychiatric genetic counseling, how we it's not his fault. And although we're not able to control how much genetic vulnerability to mental health and substance use issues we have or inherit, we can have an influence on the environmental factors and how they impact us. And he was proud to reflect when we were having our discussion about the strategies that he engaged in to promote his recovery, how he was able to break the chain of drinking and using drugs when he quit, and how his daughter was also able to break the chain, and how they were both proud to be sober together. To highlight, the healing and coping process, he acknowledged that his medication was really helpful in helping manage symptoms of depression and PTSD. Strategies to reduce stress would include having his sense of humor and reading. And these were also things that he acknowledged that he would be doing after our session as part of his self-care plan. And I think, one other thing that he wanted to mention was his social support. So really appreciating the people who have been part of his healthcare team, his psychologist, his psychiatrist, his nurse practitioner, and now me as the genetic counselor as part of his primary care team. At the end of the session, he expressed feeling lighter and that he actually planned to get physical jars to work through each of the triangles in his jar. And when I had connected with him for a follow-up call a couple days later, he reflected on how, although the discussion was emotionally hard for him, he really appreciated it and that opportunity to connect, and was really looking forward to seeing me again in our follow-up appointment. So to update in terms of how the follow-up session went 1 month after, he told me that his daughter had bought him 2 jars. So one for him to be able to think about the factors that have contributed with respect to his mental health, and one for his physical health. And so I really wanted to kind of highlight here that holistic view, and how genetic counselors, we can really help facilitate that for our clients, particularly in the primary care space. For me, he shared that repetition is helpful, especially with his experience with PTSD and the impact on his memory, and he planned to review these triangles in his jar. And in thinking about his physical illness or chronic respiratory illness, he talked about having a larger COVID-19 triangle and how that had entered his jar, and the fact that he had been vaccinated was one of his protective factors. And that was something that he kind of naturally shared as kind of applying that analogy and kind of extending it to his physical health. And when we were doing the mental health kind of check-in as part of our follow-up, he shared with me that he was proud to say that he was doing a bit of everything to promote his mental health as well as his physical wellness, including exercising more by going on longer walks. He started reading a book on coping that a friend gave to him, engaging and reaching out to friends more. He'd partnered with his doctor to increase his medication dosage and felt that his nutrition was going really well. So I hope that gives everybody a better sense of how I aim to take that holistic approach to care, and really trying to include those cultural safety and trauma-informed approaches to my genetic counseling practice at the Kool-Aid Clinic. So I've included here a set of resources for everyone to review and access, and so have Christine and Natasha as well. And we'd like to open it up to questions from people attending in today, and look forward to discussing with you. Thank you, everybody.
Great. Thank you, Priscilla, Christine, and Natasha for that excellent presentation. So we are going to begin our Q&A. So for anyone in the audience, please remember to submit your questions using the Q&A box. We'll read those out loud and then give our speakers a chance to respond. We already do have a couple questions coming through. So the first one says, depending on whether you do pre-test, consult on direct-to-consumer, or see patients post-clinical testing for PGX, what is your preferred workflow? Specifically, do you prefer to see patients in the pre-test setting?
Would you like me to take that one, Natasha?
Sure.
I would say always preference is pre-test. I think that there's a lot of work that goes into, medication history review from the pharmacy team, and really making sure we're picking a panel that's appropriate based on their concerns or questions. Like Natasha kind of mentioned early on in the presentation, no panel is the same. Not all drug gene pairs are represented equally on all panels. So I think it's really important that we kind of help weigh in on that process, given that we have that PharmD expertise. And then I think the genetic counselors have a lot to kind of offer in that space, which is what I hope we highlighted earlier on too, in terms of the counseling around testing the informed consent, and really managing those expectations, which I think is really critical with where we're at in terms of limitations for PGX with some of these indications. Anything else to add, Natasha, Priscilla?
No, I think you did.
All right. So this next question is in relation to bi-directional knowledge sharing, which Priscilla, I think you mentioned as part of your talk. And the question is, how much is too much? What might lead to transference or pivoting the discussion towards you as the provider?
So with respect to the bi-directional knowledge sharing, thank you for that question, by the way, Tara. Part of, thinking about too much from the genetic counselor perspective, it's really focusing on the evidence-based approach and understanding to the genetic factors and the environmental factors that contribute to someone's experience with their mental health. And so I know I have kind of a set plan for what I hope to share. And with respect to what the clients and patients share with me, part of it is, personal in terms of what I had mentioned, how much they feel comfortable in sharing. And that does depend on the individual, where they are in their journey and their wellness. I know that if someone has shared with me, and if I'm aware kind of in reviewing their medical history ahead of time as well, if they've experienced, significant PTSD or dissociation events, this is where we might take a little bit more time in terms of trying to be very mindful of how they might be impacted by talking about things like family history or talking about their own journey in their mental health. So again, it's hard to kind of quantify that. I think it is really kind of part of it is case by case with the clients. I might say some things like, I know that with clients who have experienced, trauma related to their mental health, or, their experience, if someone is coming in, an Indigenous clients with thinking about and reflecting on their time in residential school, some people might feel that they start to feel triggered, or they might recognize that even after the appointment, they might be feeling emotional. And so part of it is, asking the clients to kind of, as best as they can, check in with themselves, how they're feeling when they're sharing. And again, I'm trying to take a hint in terms of visual clues to check in with them, and make sure that, if there is an appropriate time to pause, like if there's a pause or a time to check in, it doesn't have to be at the midpoint. I can kind of also acknowledge, what's going on for the client at that moment, if I'm starting to notice anything, again, to help provide insight in terms of, how much sharing seems appropriate from them. Getting that history of, how much work they've done on themselves with their healing process, whether someone's actually engaged in psychology sessions with like trauma focused counseling, that also helps in getting a sense of like how triggering or how emotional a discussion could be. I hope that answers the question, Tara.
Thanks, Priscilla. So our next question from Kennedy says, I was wondering if you could comment further on the genetic counselor scope of practice in primary care. How do you decide when to refer to specialty genetic services?
I guess I'll answer that one. So thank you for your question, Kennedy. I think that's a great one. One of the things that our team did was we actually reached out to the other genetics providers in our area, not even just the ones in our immediate system, but also the alternate system that's here in the area, to talk about what patients they felt like were truly theirs, that they really needed to see, and good ways that we could triage to them very quickly, versus things that were maybe best served in that primary care space. And so Chris sort of alluded to this, that we really have two arms of our clinic. One is very primary care, where we feel like most primary care providers should be able to do a really good family history related to cancer. And then there's also sort of a more precision medicine arm of our clinic, where we're potentially seeing patients to provide genetic counseling related to concerns from a specialty referral. So that hopefully that kind of helped answer your question in terms of what we feel like really fits into primary care and what maybe doesn't. Kristen, anything you want to add?
I'll just say that I think it's a work in progress too. I feel like this is a new space for genetic counselors to be kind of landing themselves in. And I know that we have a small group that kind of gathers and kind of talks a little bit about what we're doing in our spaces. Priscilla is part of that. And there's not many of us. So if you know folks that are doing this as well, please connect. Our contact info is there. And again, I think it's slowly over time really developing what that scope is and what's appropriate in the primary care space. And I won't say that we have it all figured out yet, if we're being honest.
And I think I can add to that. I took a very similar approach as well within the primary care integration, and reaching out to colleagues at the hereditary cancer clinic in BC and the inherited arrhythmia clinic and the medical genetics clinics to really get a sense of, what is in with the scope in terms of the counseling that we can provide to our clients in the primary care space, especially considering the access and barriers to getting to a specialty appointment, whether that be in a specialty clinic, a hospital, and thinking about what makes most sense to do within that safe space of the primary care family medicine clinic as well. And so part of it was kind of identifying, if a particular client has a family history where they might be eligible for genetic testing, then, can I do some of that initial kind of discussion for that foundational understanding of, complex multifactorial conditions versus hereditary, and kind of have that warm up before they get referred to a specialty service. And then also kind of acknowledging where in the scenario where they, might not be eligible for testing, talking about how they could have a specialty referral, but also that I would be able to have that kind of that genetic counseling discussion with them in their primary care home space, so that, it's not a barrier. Like if it is a barrier for them to be able to see a specialist, that they're able to still get the information and knowledge and support and counseling that they're looking for, essentially. So that again was like part of that discussion with myself and kind of reaching out to my colleagues in the community to see what makes sense for the clients, depending on kind of their histories. And often it was kind of case by case too, where I would be actively reaching out. And I had very supportive colleagues that would just encourage me to reach out if I had questions about particular clients and referrals.
Great, thank you all. So I have another one that's a combined comment and question. So Priscilla, they said they really loved your case example and we're excited to apply a bit of what they learned today. If you could kind of role play how exactly you make that self-care plan and what does that sound like?
So I think it really starts, as I mentioned, in the contracting, and really, I think what Natasha has already highlighted. I think I do benefit from the fact that I'm building on the rapport that their primary care clinician already has with them, and that's to my advantage to already be able to talk about certain things, being part of the primary care clinic, acknowledging that I've reviewed their history and I'm aware of their experience with their what they've shared in terms of some of the experiences with their mental health, or if they're having substance issues, and also any kind of histories of traumas, kind of exploring with them already some of the things that they might feel helpful in managing and coping, exploring how they're feeling coming into the appointment. I think that helps in getting that insight and clues as to what could potentially be helpful to include in a self-care plan. I acknowledge, I mentioned already in the contracting piece, I'll acknowledge that some people find that experience of talking about their family history or sharing their experience with their mental health can draw up emotions. They might need time throughout the appointment to think about moments when they might want to take a break and engage in self-care. And then if they're comfortable with sharing with me, what at that point early on, some of the things that they do for their self-care, I can acknowledge that those are things that we can talk about at the end again with the self-care plan. But essentially I'll draw from that early discussion when we get to the part of the psychiatric genetic counseling appointment where we're exploring protective factors in terms of promoting recovery for their mental health. We'll also kind of bring that in at the end of the discussion. So I might say something like, you shared with me that, reading and going for walks was something that you really felt helped with promoting your recovery. I'm wondering if that might be something that you want to do in your self-care plan after our appointment today, or what are your plans after the appointment? Some clients will say, I'm planning to meet with a friend already. I think that'll be good for my self-care, connecting it kind of with the importance of social support. Whereas I have clients that I had mentioned already will say something like, well, prayer has been really helpful for me. I feel like, it would be helpful to do that. And I was thinking that, it kind of fits with how they're feeling in the moment as well. So I hope that helps in a little bit of the role playing and kind of tying in what I've shared.
Thanks so much, Priscilla. So I think we have time for one last question here. This question is, how are you able to justify funding for or create your position within the UPMC primary care clinic?
Want me to give that one a go to start, Natasha? So I would say, first off, we have a physician lead who's a genetic counselor champion, which is amazing. So we are very lucky in that sense, that really has advocated for what we contribute to this care model. We do bill as much as possible. So I will say we're capturing both pre and post test visits. I think that's really important. I know a lot of genetic counselors out there may like call out results or do things where there are things we're not capturing that could be technically billed, which contributes to kind of like a net positive model, if you will, from a justification of FTE effort for GCs. And I will also share too that you can really build on complexity and time from a physician standpoint. And so they are trying to bill at that max level they can based on the type of interaction. Natasha, anything else to add to?
Yeah, I think I would add that we really started off quite small. So I think initially Christine and I were alternating like a half day, which was like maybe 10% effort to start ramping up. So it wasn't like we woke up and we were like, and now we are full-time primary care genetic counselors. But I think that small incremental, we were able to sort of show benefit and that billing benefit. I think the other thing that probably ended up maybe helping us was that our clinic was really easily adaptable to a hybrid model. And so our team really did not miss a beat when the pandemic really started. So I think those were all things that were helpful in our justification.
Thank you. So with that, we're going to conclude today's member webinar. So on behalf of the NSGC webinar subcommittee, I just want to thank you to everyone that was in attendance today, as well as a huge thank you to our speakers for sharing their knowledge, their stories, their expertise. This webinar recording will be posted to the webinar page of the NSGC website within 48 hours. So with that, I hope everyone has a great rest of the day, and we look forward to seeing you at our next NSGC webinar.